treating misophonia in children and adults. And as we kind of just get ourselves going, first thing I'd like to do is welcome you. And really, again, on behalf of the team here at Duke, thank you for spending time with us. If you're watching this later on YouTube, thank you for taking the time to do this as well. We hope you like this and you decide that you'd like to come back and follow as we continue to support advocacy and information sharing about misophonia. In terms of support team, in addition to the Duke team, I want to give a huge shout out to our collaborators and partners, Jennifer Brout from the International Misophonia Research Network and Chris Edwards from SoQuiet.org, who are here with us tonight. And Dr. Brout will be on the chat box. She will be answering questions throughout today's webinar. So if you have questions as we go through the webinar, please feel free to go ahead and just put them in the chat box, and Dr. Brout will answer them as best as she can. If there are questions that make more sense to wait until the end of the presentations, we get to have our very own Dr. Brout be our moderator for Q&A at the very end. So please do ask questions. In terms of engaging with all of us in the webinar, one thing to note is that we are recording this webinar and it will be posted to YouTube. And so please be mindful of what questions you ask and what you type in or what information you share, because again, it will be posted on YouTube. And we're going to ask that everybody stay muted. This is a large group of folks, and we are here to address misophonia. So we're very, very sensitive to sound and to distractions caused by sound. I will do my best. Dr. Guzick and Dr. Brout will do their best to kind of not make any kind of triggering noises or visuals. We'll do our very best because we're super sensitive to that. And we're also asking you to stay muted. Okay, so our team supports this. This work is also supported by the anonymous families who have generously supported the Duke Center for Misophonia and Emotion Regulation. The only reason we are here is directly through philanthropic gifts from families who are able to give and who support this work. So thank you to those of you who have been supportive. We want to acknowledge and thank everybody who's here and everybody who's watching, and really thinking about you all as advocates for supporting misophonia research, education, and treatment. What we're going to do over the next hour is talk about misophonia treatment, and we're going to talk about this first in terms of what we can do for kids and families. Dr. Andrew Guzick is going to lead that. He's going to present for about 15 to 20 minutes, and then he's going to turn it back over to me, and I'm going to present for about the same amount of time. I'm going to be focusing on thinking about treatment considerations for adults with misophonia. And when I finish, we'll then open up the floor. And again, Dr. Brout will moderate our Q&A. So that's kind of the game plan. And I think with that, let's take it away. Let me minimize this and pull up Dr. Guzick's presentation. Okay, can we see his presentation? We cannot. All right, let's do it again. Why is screen sharing paused? Let's try one more time. Okay. Well, that isn't so helpful, is it? Apologies.
While you're doing this, if it's
Guzick, please take it away.
Yeah, well, thank you so much for the introduction and for welcoming me here. I'm really excited to be able to talk with y'all and can very much relate to the Zoom struggles. Here we are 3 years later, and I still find myself struggling with Zoom probably every week. So anyway, here we are. I'm going to be speaking a little bit about cognitive behavioral therapy for misophonia in kids. and how we really think about taking a family-based approach. So if we move to the next slide, just to make sure we're all using the same definitions here, the most recent expert definition that we've come to for what is misophonia is a decreased tolerance to specific sounds or the visuals or other kind of sensory aspects associated with those sounds. We call those things triggers. The most common things being things like eating, drinking, sniffing, breathing, sneezing, coughing, as well as clicking or certain letter sounds or certain words or rustling or mechanical sounds like a humming of a refrigerator or something. These triggers evoke really strong, overwhelming, sometimes hard to explain emotional experiences that are experienced as almost automatic. And this response is related to the pattern or meaning of sounds, not the volume. That might also be the case, but when we're talking about misophonia, we're speaking specifically about the repetitive or specific sound that's related to something rather than like bells ringing or babies crying or loud noises that tend to bother people. Most often these sounds are produced by another person. In the case of kids, it's most often a parent or a sibling. I would say that's often the case in adults too. And once you hear that sound, it's really hard to think about just about anything else. I'm starting to think this is a really, really central aspect of it. And finally, it causes a lot of emotional distress or problems in day-to-day living. So that's our definition, big picture of misophonia. Cognitive behavioral therapy is this big catch-all term that refers to this big family of psychotherapies. And the thing that they share in common is the idea that you might be able to change how you think and change what you do to change how you feel. And all these things are connected. Within that broad family, there's a lot of wiggle room, and there's a lot of different ways to apply cognitive behavioral therapy. We're just starting to get an understanding of what might be the best way to apply this to misophonia. And so we'll be talking about at least how we've been thinking about that as one approach of many that you might be able to seek out. So this is our kind of conceptual model of how the thoughts and behaviors play out in misophonia, make it maybe stick around and can cause problems in kids' lives and families' lives. So we start with a trigger noise, which evokes this really big, overwhelming emotional response most often an anger, agitation response, sometimes disgust maybe. Maybe there's some negative misophonia thoughts floating around. This is the worst sound I've ever heard in my whole life. It's going to last forever. They're doing this on purpose to bug me. And then there's that hyper focus, can't think about anything else. So that leads to these quick fixes because it's so overwhelming. It makes sense then that we would want to get rid of it as soon as possible by leaving the room, running away, yelling at the person to stop, or blocking it out, say with headphones or something. In the short term, this can cause a lot of tension in families, and we see a lot of arguments, a lot of tiptoeing, and a lot of accommodation around, say, meal routines, how we get from point A to point B in the car, where we can go as a family, what's going on in school. Between those responses and the family conflict, when you talk to kids with misophonia, you often hear about feeling guilty about reacting this way, or feeling isolated, feeling like they can't do the things they really want to do, or parents really want their kids to be able to do. And this can create a lot of challenges, and it really speaks to how this is not kind of part of how someone is and how big and strong those emotional reactions are. That said, we do these things because they do help us feel better at first, which long-term maybe tricks your brain into treating these noises like they are a big threat that needs to be feared. And so now we're on red alert. We're really anxious about hearing noises and maybe avoiding noises. But that kind of hyper focus and like always being on guard is going to make you a little bit more sensitive the next time those triggers come up, and the cycle might continue. So along that whole path, there's lots of different ways that we can kind of help with the way we're thinking, the way we're reacting, that might be helpful for kids trying to cope with misophonia and overcome misophonia ultimately. So there we can think about attention training, we can think about distress tolerance, physical relaxation, cognitive strategies, changing the way that you think about triggers, changing the meaning of triggers. This one's really important. I'll speak a little bit about this, how to create supportive environment in the family. And then ultimately decreasing how much we're avoiding noises. When we say mapping misophonia, we think about all the ways misophonia might be messing up someone's life or a child's life, and how we can slowly, surely help kids reach their goals and help families be happier. So if we go to the next slide, misophonia is associated with a big, strong, often physical reaction. So it's the fight or flight part of our brain is kicking in. It's red alert, something bad's happening. And there's things that we can do to actually activate the calm down part of our brains. And the one surefire way to do that is thinking about taking slow, deep breaths and really kind of doing it in a way that will maximize how much we're activating that calm down part of our nervous system. People with misophonia are always white knuckling it through their triggers. And so there's muscle relaxation techniques we can teach that will help kids gain control over how tense their muscles are, which is associated with that big emotional response. The key here is there's a million different ways you can tolerate distress. I'll talk more about the avoidance and mapping thing. That was a little, that was probably a little jargony. The key is, and with the next slide too, I'm going to mention some strategies. Different things will work well for different kids. It's about working with a child, working with a teenager to figure out what helps you feel more calm, what helps reset you. Dr. Brout, for example, has done a lot of work looking at more sensory-based regulation strategies. And there's a lot of strategies. I'm just listing a few that we've been thinking about. Attention training. We have this hyper focus on aversive noises over the last several decades. We've really come to learn how much mindfulness can be helpful in helping a person gain control over their attention. Mindfulness can be really tough with kids, but I've had the experience of working with teens in particular, but even some young kids and some kind of more playful sorts of adaptations of mindfulness to get that sense of control. If we look at the next slide, also thinking about challenging some of those thoughts that go along with misophonia. Maybe they come after that immediate reaction. They're doing this on purpose to annoy me. This is never going to end. This is the worst feeling ever. Some strategies we might take there, things like reframing. They may not realize they're making that sound on purpose. Distancing. My misophonia is telling me this person is a jerk. Maybe they're not actually a jerk. And accepting the emotional experience that you're having instead of fighting it. I can feel my body tensing up and getting hotter. I'll let myself feel this anger. Something that I've been doing a little bit with some of the families I've worked with is trying to change the meaning of triggers through some kind of exercises that are giving a positive association with those triggers. So, for example, worked with a girl who had a trigger related to pen clicking. And so at the same time, we go to the next part of the animation. This is a little funky on the animation here. She really liked art. She really liked hanging out with her mom. So these were good things, led to positive emotions, which we can see on the next part. If we want to click the next part of the slide there. And so then if we kind of figured out a game where she and her mom were taking turns clicking a pen, drawing something, and she was able to turn her attention more to the drawing and the fun experience she was having with her mom. And eventually, hopefully, the idea is that this can to disconnect that big, strong anger reaction from the pen clicking to more, oh, this is something I can do that's fun with my mom. So that's all summed up on this next one. But we can keep moving along. I got a little fancy with the animations, like I said. Next slide. Involving families. I have just a couple slides on it here. I could speak for much longer about this, as I'm sure Dr. Brown could as well. But some things we want to think about are for younger kids in particular, is really thinking about giving rewards and positive attention for coping with misophonia. So for younger kids, whenever you see that they're working really hard to challenge their misophonia and say, eat with the family, making sure they're recognized, that there's genuine enthusiastic praise. I love it so much when you're able to come eat with the family. It means so much to us. I know this is hard for you. We really appreciate that. And trying to give some age appropriate rewards for that. Now, on the flip side, we need to accept the emotional experiences kids are having, but not necessarily aggressive behavior. So we should still use consistent age appropriate fair consequences for unacceptable behavior. So, kids with misophonia will often hurt their siblings, maybe hurt their parents, maybe scream and say really hateful things. For that, we would still certainly think about setting up a system where there are fair consequences for behavior, not the emotion, but the behavioral reaction. That said, so if we go to the next slide, we want to also change our communication around misophonia. One way that we do this, we took this from kind of other sort of disorders related to big, strong emotions, is giving a name to misophonia. And that all of a sudden we're teaming up against misophonia. It's not, oh, so-and-so, you're being a huge pain again, you're yelling at us again. It's misophonia is the problem. It's not the other family member, which can go both ways sometimes when misophonia becomes part of the family life. That said, it's totally normal to be cranky if you're a kid who has misophonia. I mean, this is really hard stuff to deal with. So we don't want to give a whole lot of attention to those. We don't want to get into a big power struggle related to just using your manners and you're being so rude. We want to, if it's minor and we can ignore it, we want to do that as best as we can and really focus on the wins and when things are going well, because then you can end up really getting into a situation where there's a lot of tension and a lot more conflict in the family and maybe less of the positive experiences. We go to the next slide. A couple of different communication patterns we might think about. We want to really amp up supportive communication. And supportive communication is characterized by acceptance and confidence in coping. So I know how overwhelming it can be to sit with us for dinner. That's accepting that overwhelming emotional experience. Whenever you're ready, I know you have what it takes to sit with us for the last 5 minutes. Whenever you're ready, that's accepting, it might not be today, but I know you have what it takes is confidence that your child can overcome this. If I want to click on the next one, I think those will be, there it goes. Yeah, so do more of that. And then on the flip side, we'll sometimes fall into a trap of being overprotective because there is a lot of empathy from parents about how hard this is. We'll say, well, don't worry, we'll never make these noises around you. It's a hard promise to keep a lot of the time. So we don't want to make promises we can't keep. And then same time, there's a lot of running out of patience. It's no big deal, just get over it. That critical language can create more tension as well. So if we do less of those two things, which will be the next animation, and then between those two things, we get kind of supportive communication, which is the next animation. All right, and now I'll talk about that avoidance part, and I'll try to wrap up here, make sure we have time to hear from Dr. Rosenthal at all. Avoiding stuff is kind of a core part of misophonia. These triggers are so upsetting, it makes sense that we'd be annoying them. Most common, family members, meals, but also public places and other people outside the family who might be making trigger noises. So with the family, if we go to the next slide, we'll think about gradually, once we have some of these coping skills on board, once we have that supportive communication in place, once we have some confidence in dealing with these triggers, we'll think about reaching our goals that misophonia has been interrupting. So we might work with a child who is, say, wants to be able to play video games with her sister again, but she can't because she can't stand the hearing her breathe next to her, or eating in the cafeteria with my friends, or riding in the car with my mom, which I can't stand because that closed space, I can't get away from the noise. That might be too hard to do today, but with these coping skills on board, we might want to start thinking about those steps being things like playing video games on the other side of the room, or eating with one friend at home before we go to the cafeteria with everybody where it's really overwhelming, or riding in the car but using headphones first before we start thinking about maybe reducing those too. So those are things we might start thinking about building in. I think that's it for my part. We have some studies going on at Baylor. We have an adult study. So if you happen to be in Texas, or more specifically Houston, you can come on in and we'll take a look at the electrical signals that are represented on your scalp, and see how that could provide some insights into the brain basis of the reactions to sounds. And then on the other hand, we have a study for kids which is the next slide, same email, misophonia@bcm.edu, that's Baylor College of Medicine.edu, where we're doing interviews with parents and kids to learn about their experiences, asking them to fill out questionnaires, and then following up with families once a month for 6 months to see how things go, and see if we can start understanding, patterns of resilience and more challenges when it comes to misophonia. So if that's of interest to y'all, we would love to have you. This is available to pretty much anyone in the country. You don't have to be in Texas for the child one.
Okay. So I'm going to take it from here and talk some about misophonia and treatment considerations with adults. I am going to talk from the perspective of a clinical psychologist, which is what I am, but I'm also going to talk more broadly from a more multidisciplinary perspective. And that's because that's what I think is probably the most helpful way to think about this whole conversation. Before I get going, I'm highlighting here on this slide disclosures that I have. I've put in bold those disclosures that involve any type of payment to me directly. This way you can see and evaluate for yourselves if I appear to be biased in any way. Okay, so let's go through some big picture considerations. First thing to know about treatment for misophonia for kids, for adults, for adolescents, for anybody and everybody around the world is that there is no cure. There's no cure for a lot of things either. And so I don't want anybody to feel down and out about that. Misophonia research has really just begun in earnest in the last 2 years. The last 2 years of misophonia research has produced more scientific studies than all previous years combined. Think about that. And the first study was only in 2013. So we're really now in what I've been calling the second wave of misophonia research. First wave were the very early studies from 2013 until just a couple of years ago. Now, science is kind of moving things to the next level. We have a long ways to go still, let's be real, but we are beginning to make some really nice progress. A cure is not there yet, though. Secondly, there are no evidence-based treatments yet. We're going to talk some about what we can do for adults using a kind of an evidence-based framework that I'm going to orient you to. And Andrew just talked about CBT as a framework, a flexible framework for kids with misophonia. But here's the thing you have to know. The thing is, there is no gold standard evidence-based specific treatment. I think there will be, but there isn't yet. Okay. There are no controlled studies yet with any medications, no controlled studies with any medications, brain stimulation, apps, games, psychedelics, diets, surgeries, you name it. There's no controlled study. So we kind of have to just all be on the same page about this, that we're very early on in trying to understand scientifically what might work for misophonia. And on that same kind of vein, neuroimaging studies that have begun to look at what parts of the brain are really most important in misophonia, they actually haven't precisely identified specific, unique to misophonia brain mechanisms. There are really intriguing, great new studies. It's very, very exciting time to be doing this research, but we aren't at a conclusive, definitive place yet. And so we don't know if we change this or that part of the brain, if that should change responses in misophonia. More work needs to be done. Now, shifting to treatment studies, there actually is only one randomized trial for misophonia that's ever been done, and it was a group therapy. It's a 7-week group therapy for adults done 3 hours at a time. This was done by the incredibly successful and prodigious in misophonia science Amsterdam group. You can look at their work. They've done terrific work, but this is the only trial, and it's sort of just a preliminary first trial. They are now planning to start doing a second trial with children. But again, only one randomized trial showing some promise. It was a group therapy, but it was a cognitive behavioral therapy type of approach. There are some smaller trials. We call them open trials. These are uncontrolled. You can't make any real definitive conclusions from them. And there are 4 of them. And most of them also used various types of CBT or cognitive behavioral therapy interventions. Now, one of the behavioral therapy interventions inside of CBTs is what's called exposure therapy. We could take the entire time today and talk about just this one point. We're not going to do that. All I'm going to say on this slide is that we do not recommend using traditional habituation-based exposure therapy for misophonia. And there's lots of reasons for that probably most of you intuitively already know, which is that patients and families don't find this to be an acceptable approach. Dr. Guzick led a study with his colleagues at Baylor that recently found this, and they published this in, I don't remember the journal. Andrew, you can put it in the Zoom. Maybe you can put the reference. But they just published that this is the least preferred of all possible treatments by people with misophonia. So look, if a treatment isn't something that someone's willing to do, it's not particularly helpful. The next thing I want to point out is that we recommend that you avoid treatment from people making extraordinary claims without reasonable evidence, and avoid those people who are providing treatment who oversimplify misophonia as being something very simple and the same for everyone. The more definitive and the simpler it sounds to you by a provider, the more I would be cautious. Misophonia is complicated, and we don't know what works quite yet. The 8th point I'm making here is I don't think you actually need to find an expert, a so-called expert. You all are really the experts, but there are providers who are developing expertise. I don't actually think you need to find an expert in misophonia. What you need to find are providers who do evidence-based interventions for the kinds of problems that you or your family member, or if you are a treating provider here today, that you know how to provide for the types of problems that this patient is presenting with. Okay, so we can rotate out of the medical model of thinking about misophonia is the same for everybody, and we can start thinking about it in a little bit more complex way, that it's actually kind of complicated, and people are different, and they have lots of complexities. They have different co-occurring kinds of problems. It's a kind of thing that lends itself to being really flexible with the type of evidence-based treatment that you receive. 9 here is try to stay informed about misophonia. You can use us, you can use So Quiet, you can use, there's many other wonderful resources online to use to stay empowered, stay informed, stay educated, because things are rapidly advancing, and what was written about 5 years ago is not really what's being written about today. Things are moving really quite quickly in this space. Okay, last point here, and then I'm going to move into treatment more concretely, is we're going to recommend here that treatment for misophonia, wherever possible, if feasible, even if it has to be stitched together in a sort of janky way, ideally, you're going to have psychotherapy be one part of a multidisciplinary model that uses other professions. So audiology, occupational therapy, physicians of various different disciplines. And why we might do this is that a multidisciplinary problem might be best treated from a multidisciplinary set of solutions. And as of right now, misophonia is not considered to be a psychiatric disorder or a mental health problem. It's not considered to be a neurological disorder. It's not really considered to be any one thing yet officially. So, it might be one day. I think it likely will be at some point, but it isn't yet. So if we think about the reality of that, it is a disorder that sits in the space between a bunch of different disciplines. And that's okay. We can conceptualize it that way, and we can then think about interventions that also use multiple different disciplines. So when you do a multidisciplinary approach, you want to have a primary point of coordination. And this is often pediatrics or primary care. It doesn't have to be, though. It could be that it's the psychologist or the psychiatrist or the OT or the audiologist. The point is that you want to have one person, ideally, who's helping you be able to navigate your coordination of care across the other providers so that you've got kind of everybody on the same proverbial page. This also involves continuing to seek education and support for misophonia. And when you get to the psychotherapy part of all this, and perhaps the occupational therapy part, and in some cases, the audiologic part, the treatment is going to be learning ways to prevent and manage symptoms, to reduce impairment, and ultimately to create empowerment, self-efficacy, and hope, right? You want to have a life that is experienced as free of suffering, a life that can be lived where you're able to live a valued life despite misophonia. The same way that many people have any other kind of medical problem, and they strive to live a life despite having that problem that's full of kind of their values and the way that they wish to live. All right, so what can we do? So in audiology, remember, the audiologists are the hearing experts, and this is a sound intolerance problem. So our audiologists can assess and quantify hearing sensitivity and other sound intolerance problems. So hyperacusis is the primary other problem to get assessed, and the audiologists are the ones to do this. Hyperacusis is when you're sensitive to the loudness of sounds, not to the meaning-based pattern. So our audiologists are the ones that are really the experts in hyperacusis and in offering sound-based therapies to intervene for hyperacusis and or misophonia. Occupational therapists in the world of healthcare, they are the experts in sensory processing. So these are the people that think about and treat sensory over-responsivity every day. They help people with daily functioning and getting through school and getting through work and getting through home, day-to-day kinds of tasks by managing how their sensory input is more effectively processed. So these are fabulous people to turn to for ideas about how to cope effectively. Neurologists are going to be helpful for treating things like migraines or dizziness or head trauma or other kinds of neurologic conditions. If someone is interested in medications off-label to help with some of the symptoms of misophonia, psychiatrists or other kinds of med prescribers that can prescribe pharmacotherapies those are the folks to be turning to. And then psychology, or more broadly, psychotherapists, help and change patterns of learned behavioral, cognitive, social, attentional, and physiological responses in contexts that they occur in. These are also the professionals who treat the co-occurring mental health problems using evidence-based approaches. And we know, again, that people with misophonia sometimes have no co-occurring mental health problems. We also know that people with misophonia sometimes have any of a wide range of co-occurring mental health problems. So getting treatment for misophonia also might look holistically like getting treatment for those other mental health problems that are complicated by misophonia or are making misophonia worse. Okay, turning kind of abruptly over here to CBTs. Andrew mentioned it earlier, CBT is not a thing. CBT is not a treatment. It is a family of treatments. 20 years or so ago, we used to call CBT a thing. We would talk about doing the CBT, but now that's sort of like trying to say, I'm going to just take the antidepressant. Really, there's not one antidepressant. There's many, many, many different brands, different types of antidepressants. And the same is true with CBTs. There's a lot of different CBTs. Some are really cognitive, some are really behavioral, some are really focused on body and emotion, some are focused on interpersonal and relationship, some are focused on attention. You get the point. There's a lot of them, and all of them are talk therapies. So for those of you who are new to CBTs, this is a psychotherapy. It's a type of talk therapy, but it's not just supportive. It's supportive in a collaborative way that's tailored, that's structured, that's brief, and that's really targeted towards very specific change processes. CBTs are the psychotherapies that have the most scientific evidence to support them, but there are other treatments that work for all sorts of different mental health problems. These are not the only treatments that work, but they are the ones that have been studied the most. Now, here's the thing that's key. If you're starting to sort of drift away, or if I'm using too much jargon, let me try to bring you back in here. Some CBTs can be applied in the same uniform way for everybody, in a very manualized way where you're replicating the same thing over and over again to everybody. That's how some CBTs work. And I've just thrown alphabet soup acronyms at you. And if you don't know these, doesn't matter. This is just to make the point that there are these branded treatment manuals that you kind of, when you do them, you're doing them the same way for everybody. Some CBTs are like that, but not all are like that. When you do CBTs, you also can tailor them to the individual in very unique and different ways, using principles and strategies that are common across the treatments. And I'm going to now turn us for the rest of this time talking about process-based therapy, or PBT, process-based therapy, as a framework, a new name. It's a new framework. It is not specific to CBT. You could use this with other interventions. But it is really very well aligned with using CBT. So this is what we're doing at Duke, and we're kind of testing this out and piloting this. This is what I was doing earlier this afternoon with someone. It's what I'll be doing tomorrow with someone. It's sort of what we're thinking as we're building out flexible ways to approach treatment for adults. So very simply, PBT, process-based therapy, this is a way of transdiagnostically helping people in a principle-based way that's tailored, it's collaborative, it's structured but has flexibility to the person, and it's fundamentally driven by the core tenet of using evidence-based approaches to help people. So this is not eclectic therapy. This is not you just do whatever, whenever. This is not that. This is really a framework that is structured and principled, but is also flexible. So let's work through that for just a second. So transdiagnostic is just a buzzword for works for people across different types of diagnoses, different complexities, different problems. Principle-based, I put some examples in here of what I mean by that. We're going to focus on leveraging people's strengths, their capabilities, their willingness. We're going to use what are the so-called common factors in PBT. This is essential to all treatments that work. Empathy, support, validation, trust, a strong therapeutic alliance. These are all things that are what we call common psychotherapy factors, which basically means the things that you find in any good treatment. Any treatment that works is likely to have these core common components. Nobody owns them. They're just there in good, solid therapies. So PBT is going to leverage all of that. Why? Because that's evidence-based, not because I say so, but because decades of science says these kinds of things are really essential in determining what works for whom. Another principle is that change is nonlinear. This model says that when we help people, it's not simple. It's not so simple that if we just simply change how someone thinks, it's going to change how they behave. It's not so simple that if they're triggered, they simply have an emotion and it's always an emotion, or that they simply have a physical reflex and it's always a physical reflex. This is oversimplifying what is essentially a very complicated phenomenon. So the assumption here from this model is this stuff is not simple. Change is nonlinear. Change is transactional. Things impact each other in really complicated ways at the individual level. By tailored, we mean that problems, contexts, and change processes are going to be really different across people, and within people over time can change. We also mean here in PBT that patterns are really complex and they can be connected in networks. So I'm going to talk about that. You'll see what I mean by that in a minute, but it's a fundamental idea here that these patterns that are a part of misophonia, they're complicated and they connect to each other in networks. So difficulties with bodily overreactivity is connected to how we think, which is connected to what we do, which is connected to how we relate, which is connected to how we feel about the people that are closest to us. But all of these things are really in a network. They're not linearly related to each other in a simple way. By collaborative, we're going to focus on building a strong therapeutic alliance, empowering patients, and creating a sequence of interventions that are based on what that person needs, not what a treatment manual that's cookie cutter says they need, what that person needs. We're also going to change course as needed. We can do this in weeks or we can do this in months. It really just varies on the complexity of the person and what they want to do. We can include family in this approach as needed. We're going to self-monitor what to change based on what the person wants, not what I want, but what the patient wants. And again, evidence-based, we're going to follow measurement-based decisions in what we do. So, it means things like what we choose to start with might be informed based on what the measures say is more severe. Or it might be based on how we're doing over time as we're making interventions. We're seeing if they're working. And based on that data, that will determine collaboratively whether we want to keep doing the same intervention or whether we want to shift gears and try something different. All of the interventions we use are going to come from evidence-based treatments. We're going to borrow them, like the old arcade game claw, where you put the money in the machine and the claw goes down, and you lift up the ball, or you hope to lift up the ball and pull it out, right? We're going to do the same thing with treatments that work. We're going to go over to them. We're going to lift up the parts that work, and we're going to borrow them as needed. We can do this in a manualized way if we think it makes sense, or we can stitch things together in a prioritized, tailored sequence. Okay, it's a lot of words, but Zach, what does it look like? It looks like in the first few sessions, we're going to focus on assessment, relationship building, therapeutic alliance, and orientation to the model. This is what this is. So we're going to assess misophonia using psychometrically sound measures. We're going to assess sound intolerance, sensory intolerance, past and current mental health problems, psychosocial history, treatment goals, barriers. We're going to do a lot of assessment in these first few sessions. We're going to spend a lot of time trying to build trust and safety, being supportive and validating, helping patients feel empowered about what they do, letting them have choices in what we get to do and how we do it. We're going to be building this therapeutic alliance, and therapeutic alliance is essentially, are we going to be two trains leaving the same train station, going the same speed in the same direction towards the next same train station? Are we doing that together, or are we going different ways, right? We want to be going together with a shared understanding through collaboration about what we're trying to achieve and how we're going to get there. And then there's a lot of orientation to this model, a lot of psychoeducation about the science of misophonia, the neurobiology and biology of what happens with things like freeze responses and fight responses and flight responses. Right, we're going to talk about learned patterns. We're going to talk about conditioning and learning. We're going to talk about emotion, cognition, attention, behavior, and so on. We're going to talk about all these things and in a way that's tailored to that person. We're going to talk about these things as they are, not as one person says they are. We're going to sort of talk about them in broad ways, right? So emotion is complicated. Emotion is not just the experience of saying I feel something. Emotions have three parts. Emotions have what we feel in our body, so our bodily reactions, and even more broadly, our biological reactions in our body. That is a part of emotion. They also include what we do behaviorally, right? Are we fidgety? Are we restless? That is emotion. That's just the behavioral part of emotion. And then cognitively, subjectively, what do we think about? What are we noticing our thoughts to be and our appraisals to be? Emotion is all three of those things. It's not one of them. It's actually all of them. So we're going to talk about things in that way and help people come to understand what their patterns are. The second phase is really where we look at the patterns. In these patterns, we're going to spend a few sessions really doing a deep dive, what we call functional analyses, which is just a kind of core cognitive behavioral old school way. It's kind of the screwdriver of evidence-based cognitive behavioral therapies for assessment. It's something we just kind of use pretty regularly for decades to try to understand patterns. So what causes, what maintains reactions, where, when, and how should we intervene? What are the usual things that happen before, during, and after someone is triggered? What are the patterns before, during, and after across how they communicate, what they think, what they're paying attention to, what's going on inside their bodies, and what are they doing behaviorally? We're going to look at these different reactions, and we're going to use a kind of a grid visual to do this. So literally what we do is we ask patients to fill these out, and we fill these out with them in the therapy session as well to kind of really flush this out. What we see when we do this is everyone looks somewhat similar and somewhat different. Everybody is not the exact same. People have really different patterns, although there are some shared similarities, of course. So as we do these patterns, we start to populate this patterns grid. And as I'll show you in a minute, this becomes essential as a tool to determine what we're going to change and how. Okay, so we started building out this patterns grid to figure out what are our patterns. Our next sessions are going to involve choosing treatment targets together, prioritizing them, and then learning new ways to prevent and manage being triggered to reduce impairment in functioning. Therapeutic procedures, what are they? Well, I'm going to tell you a whole bunch real quickly, but the idea is that we're going to introduce and give options for patients to choose which interventions they are willing to try to use. They're going to choose them, we're going to teach them, train them, role play, rehearse, shape, practice. We're going to do this, and we're going to evaluate how it's working over time. Now, which patterns do we prioritize as the number one, number two, number three, and so on? There's 5 factors to consider in no particular order. How distressing is each pattern? How impairing is each pattern? How central or core is each pattern in a network to the rest of the patterns? And how motivated is the patient to change that particular pattern? So we're going to prioritize using those factors, and we're going to sequence what we do to intervene based on what's prioritized. So a patient might say, Zach, when I enter a new place, I'm just always on hyper alert for trigger sounds. Okay, well, we can understand that as a type of pattern, right? That's a type of pattern we might call hypervigilance. They might say, well, what happens is I feel physically overwhelmed by the sound and it doesn't go away. We know as the kind of mental health professionals that this is what we call heightened autonomic arousal, right? This is being overwhelmed in the nervous system. They might say, well, after the trigger goes away, all I can do is just sit there and think about how disgusting that person is and how much they ruined my day or my life. Well, we know that what they're talking about there are thoughts, and of a particular type, they're talking about what we might call automatic thoughts. Okay, so we first figure out this pattern, these different patterns that are there. And then what we do is we work with the patient to figure out how to prioritize them, right? So for this example, before being triggered, if the pattern is hypervigilance, we would offer various different interventions to reduce hypervigilance. Well, the patient's rating this as their second priority. Their number one priority is while they're triggered, they want to reduce or tolerate the intense autonomic physiological arousal. And in their own words, it'll sound different person by person. For some people, they're going to describe that as their chest being tense. For other people, they're going to describe that as feeling like, they're sweating. People are going to describe it with different experiences, but it's autonomic arousal nonetheless. So, okay, that may be where we want to target, but we also know the third priority is to change the content of the thinking patterns, because that was also, as we saw here, that was also part of what was reported as a pattern. Okay, but that's number 3. So we're going to start with number 1. And what we know is that we have interventions that work for all 3 of these patterns. Now, this hypothetical person wants to do physiological during as their number 1. So we would offer various different types of evidence-based interventions that reduce sympathetic nervous system activation, not necessarily proven for misophonia specifically, but proven for many, 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 many people of different types for many decades. So we would sort of leverage the evidence-based science in general as a reasonable option to consider in the absence of anything scientific that is unique and specific to misophonia. Patient chooses whichever one of these they want to do, and away we go. So that's kind of the idea. Now, if you zoom out even more broadly, I got to do this really quick because of time. There's a whole lot more we could do. So there are a lot of different PBT interventions you could choose. Here are examples. You could focus on decreasing vulnerabilities to being triggered, changing the bodily reactions, helping improve attention, changing behavioral patterns, improving communication patterns, changing unhelpful thoughts, providing support and validation, addressing patterns of avoidance, improving distress tolerance, identifying values across different parts of the person's life that are negatively impacted by misophonia. We can offer resources. We can provide psychoeducation. All of these are all part and parcel of a PBT approach. And if we drill even deeper into just 4 of these that I chose to dig deeper into, I won't read all of these. You can take a look and you can kind of see more specifically what we mean. All of these are individual evidence-based interventions that could be potentially applied as part of, not as a cure and not as the only part, but as part of helping people with misophonia. And again, we offer the options and the patient chooses. That's kind of the idea here. I had a case example to give you. I can zip through this, I promise. So this is a fictitious case example. It's not a real person, but it's sort of an aggregate of people that I've treated. Here you've got a person, 30-year-old Black cisgender bisexual married woman, history of anxiety, depression, and misophonia. That combination is fairly common to see clinically. Primary goal, I want to deal better with misophonia because I don't want to get fired. So after orienting the treatment approach and getting to know history, we agreed to a treatment plan. We had a really clear alliance on what we wanted to work on. We did this kind of functional analysis to figure out patterns, and it looks like this. This is kind of like what it ends up looking like is patterns get labeled. You can just read through them, and then numbers get applied. And this patient in this example chooses tension in her chest and breathing shallow before being triggered as the number one thing to prioritize. Number 2 was communication strategies looked like being kind of inhibited or being more passive in indirect with verbal aggression. So these were the number 1 and number 2 things that this person wanted to change. So this is what we started with. Well, what do you already know how to do to change those things outside of the context of misophonia? And using kind of motivational enhancement strategies, patient told me, I've done this thing before, and she described it, and it sounded a lot to me like muscle relaxation. So I asked her if she wanted to learn how to do that again, and she said, yeah, let's try that. So we did that. I trained her in that. She did that a ton as home practice, not while triggered, but in context before being triggered, when she was anticipating being triggered, but wasn't actually triggered. She does this work, she practices it, problem solves, practices more, starts to see improvement. Now, after a few weeks, we work on the next pattern, which was inhibited communication. Offering options, empowering her to choose which evidence-based approach to use to improve how she communicates. We do this, and you get the idea. It's sort of a rinse and repeat approach where you together pick the thing to target, bring the interventions to bear, the patient chooses, learns, applies, and then we see what's working. So in summary, this is a flexible approach. This is the part the mental health person might do, but again, as part of the broader multidisciplinary approach. You can incorporate co-occurring mental health problems into this, or just use it directly for misophonia. Caveat here is we don't actually know that this works, right? This hasn't been subjected to any rigorous testing any more than anything else has. So we're piloting it, but we want you to be really kind of cautious and mindful that we're not here to exaggerate a claim of effectiveness. We're here to say this is what we're learning how to do, and we're hoping that we can find a way to make this work, but we don't actually know for sure. And similarly, we don't know that multidisciplinary models work the best for misophonia because that hasn't been tested either. The takeaway is that we need time and we need funding to study all of these things in order, as soon as possible, to develop treatments. I'm going to stop there, and we're going to be happy to go over time to do Q&A. If you have a desire to keep learning, You can get to us on Instagram at our Duke Center for Misophonia Instagram, or our new YouTube channel we've just started, for which we'll post this video. And you can follow our website for updates. Our next CMER webinar will be in July, and we're going to have Dr. Prashanth Prabhu, who is studying misophonia in India and is really pioneering some new approaches. He's going to come talk to us about his work from a speech, language, and kind of audiology perspective for misophonia. Okay, so I'm stopping there. And Jen, I know we're right at the end of time, and I did a pretty unskillful job at managing time, and I'm overly ambitious in sharing information. I know
That
you're
was
surprised.
wonderful, Zach. And I tried to answer a lot of general questions.